So I think it's 12. Thank you, everyone, for joining us today. This is a very special lecture, as many of you know. This is the Vivian Rakoff Memorial Lecture. Dr. Rakoff, who was our former chair and has done so much for our department, and it's really to have you all here today. And I'm going to be moderating your event as our CPD director. Before I begin, I want to start with a land acknowledgement. This is an online land acknowledgement. I'd like to begin to acknowledge the land on which we work, study, and live. Before I read it, I want you to take a moment to situate yourself and think about the land under and around you. We recognize that many Indigenous nations have a long-standing relationship with the territories upon which the sites of the Department of Psychiatry are located that precede the establishment of the University of Toronto. We acknowledge our presence on the traditional territories of many Indigenous nations, including the Mississaugas of the Credit and Anishinaabe and the Chippewa and the Haudenosaunee and Wendat people. Today, this land is home to so many diverse First Nations, Inuit, and Métis people, and we're grateful to have the opportunity to live, work, and gather on these territories. We acknowledge that Toronto is covered by Treaty 13 signed with the Mississaugas of the Credit and the Williams Treaty signed with multiple Mississauga and Chippewa bands. Since this event is a virtual gathering, a singular land acknowledgement does not fully capture the richness of the distribution of across many locations. There are few places on earth someone before us has not called home. So thank you for that. I do want to acknowledge Dr. Gina Rakoff. I think she may be here as well. I wanted to thank her for being here as well, as it is in honor of her late husband. This memorial lecture. I'm going to today's lecture is about depression care for the people with cancer, a 15-year journey. And it's a great pleasure to have Dr. Jane Walker here from Oxford to speak today. And I really want to thank her for her time. I know it's 4 p.m. In England, but I would really appreciate her joining for our noon hour citywide grand rounds and special memorial lecture. An evaluation link will be sent to you, all the attendees, after today's presentation, and your feedback is always appreciated. The next citywide grand rounds is the Mary Seaman Lecture with respect to the adaptation export of Western British psychotherapies. And we've got a wonderful speaker, David, who's going to be speaking on that. And we also have, on that same day, our Future Psychotherapy Conference, so please consider attending as well. Okay. So thank you. So I'm going to introduce our speaker in a little bit more detail today. And Dr. Jane Walker is a researcher at the University of Oxford, UK, and a consultant-liaison psychiatrist. Her research focuses on psychiatric care of patients with severe medical illnesses and includes large epidemiological studies of prevalence of depression, suicidal thoughts, and other symptoms in patients with cancer. Dr. Walker also co-led three SMaRT Oncology trials, which evaluated collaborative care treatment plans for patients with cancer and depression. Dr. Walker is an expert in the use of problem-solving therapy and behavioral activation for patients with life-limiting illness, as well as working with individual patients. She trains and supervises other clinicians in these therapies. She's also an executive coach and specializes in coaching clinicians. Without further ado, I'll pass this presentation on to Dr. Jane Walker.
Thank you, Raz. That was such a wonderful introduction. Can you see my slides okay?
Yes.
Great, thank you. So good afternoon, everybody. It's an absolute pleasure to be here with you today. And I'm particularly honoured to be given this lecture, which, as Raj says, is in memorial of Dr. Rakoff, who I know was such an important and special person in your department. So as Raj said, I'm going to talk to you today about depression care for people with cancer. And I'm going to tell you about a 15-year journey that I and my colleagues have been on, trying to improve depression care for people with cancer. I'm going to start today by talking a little bit about the problem. So we'll talk about the background of cancer and depression and what the problem is when those two things go together. Talk a bit about a new approach that we've developed to try and address that problem, how we've evaluated it in clinical trials, those SMaRT Oncology trials that Raj mentioned, and then finally come up to date to the end of the journey, or where we are in the journey today, which is implementing this new approach in routine care and what the experience of doing that has been like. So let's start with cancer and depression and what this problem is. When we think about cancer, and particularly when we think about cancer these days in 2024, we tend to think of it a bit like this. This is often the type of image that comes into our mind. So it's a shadow on a scan. It's a blood test where there's a finding that is unusual or worrying. We think about tumours and we think about cells that are misbehaving, not doing what we want them to do. And when we think about cancer in that way, in a fairly biological way, I suppose, then I'm sure you'll agree that medicine has made huge progress in treating cancer. We now have technologies that we didn't have a few decades ago. Certainly during my career as a doctor, we've made huge progress in treating people's cancer, reducing those tumours, those markers, and prolonging people's lives. And when we think about that in a bit more detail, we can think about survival rates. So these are some figures from a paper that was published very recently, just in the last couple of weeks actually, in a publication called Scientific Reports. And these figures show us the age standardized cancer mortality rates in Canada. So if we just have a quick look at these, you can see that all of these small figures are telling us about mortality rates for different cancers, all in Canada. So, for example, we have bladder cancer up at the top there, coming down to thyroid and uterine cancer at the bottom. And what these show us are the mortality rates up the side, up the y-axis, and along the x-axis, we're looking at years. So time from 1950 up to quite recently, 2022. And what you can see here with these lines, the blue lines are for males and the yellow lines are for females, that essentially, if you look at them as a whole, the lines are coming down, the rates are coming down. So the mortality rates are getting better, survival is getting better. We're doing a fantastic job of treating those cancers. But what about the quality of these people's lives? If people are living longer with cancer, beyond cancer, what about the quality of that life? So this photograph here is an actor who worked with my team for a while, and he's going to represent John for us, who is a patient that we're going to talk about today during this lecture. John's 55. He's had a diagnosis of colorectal cancer, and that has responded really well to treatment. His oncologists and his surgeons are really happy. They say that his tumour size has shrunk dramatically. He's not going to need much more treatment. He's doing really well, and they're really pleased about his survival, his prognosis. Sadly, John is feeling rubbish. He's become very depressed. And when we talk to him, he says that actually he feels so bad, he wishes that he died. He wishes that he hadn't woken up from the operation to remove his colorectal cancer. Now, I don't need to tell you in this audience that John has major depression, and I don't need to give you information about it because you all know about major depression. But just to remind ourselves that this is a psychiatric illness. We define it using criteria that we tend to use in the DSM-4, DSM-5 these days. It isn't just distress. It isn't something that will go away by itself. Patients with major depression have low mood, anhedonia, so loss of interest or pleasure, other symptoms such as problems with sleep and appetite, poor energy, feeling fatigued, and this impairs their functioning for many weeks, often for months. And it has huge effects on their quality of life. So how common is this problem? How common really is major depression in people with cancer? How many people are like John? These are the results of a study that I did with my colleagues about 10 years ago now. And we were studying the prevalence of major depression in cancer outpatients. So these were patients who were coming to cancer clinics. They were in Scotland, in the UK, and they were coming to our National Health Service cancer centres. The studies of more than 21,000 patients. And what we're talking about here is interview-based diagnoses. So diagnoses of major depression using DSM criteria. You can see here that the prevalence of major depression varies in the different cancer clinics. So it's about 13% in our lung cancer clinics, going down to about 6% in genitourinary clinics. So in the genitourinary clinics, that would generally be gentlemen with prostate cancer. But overall, we're talking about 10%. About 10% of cancer outpatients have major depression. That's pretty high when you think about the number of people who are coming to cancer centres, the number of people who have cancer. Now, as I said, these were cancer centres in Scotland, in the UK. As you know, our National Health Service is free at the point of access. All of these patients would have primary care doctors, general practitioners. They'd be seeing oncologists, oncology specialist nurses, and the cancer centres have psychologists and some psychiatrists as well. So bearing that in mind, what percentage of these people who have major depression are getting treatment for it? Well, you might imagine that that will be really high, but actually it's pretty low. 73% of patients coming to cancer centres who also have major depression are not getting effective treatment for that depression. So you can see here this round, the orange circle, 73%. About a quarter of patients were taking an antidepressant, and that was at a minimum effective dose. And very few, only about 5%, were seeing someone like a psychiatrist, psychologist, psychiatric nurse. So this is really quite surprising and shocking, given, as I said, the cancer centres that these patients were coming to, the health system that they were being treated in. So what's the problem here? Why is major depression inadequately treated in our cancer outpatients? Well, there are two big problems. The first is that depression is not identified in the first place. We don't tend to ask patients how they're feeling when they come to the cancer centre. We certainly don't ask them about symptoms of depression specifically. And patients often don't mention it. They think it's normal to feel depressed when they have cancer. It's normal to feel fatigued, to not be sleeping very well, to not be interested in things. And sometimes they don't tell their oncologists or their oncology nurses how they're feeling because they're worried. They're worried that people will think they're not coping very well with the cancer treatment, and it may even be stopped. Even if the conversation is had, often the diagnosis isn't made. The clinicians who see these patients are not sure how to make the diagnosis. And even if they do, then we come on to the second big problem, that effective treatment isn't started or isn't given. Often patients aren't offered treatment for their depression, even when it's diagnosed, because again, people think it's normal to have depression when you have cancer or some other kind of life-limiting illness. Oncologists, primary care doctors are maybe worried about prescribing antidepressants for these patients. They're not sure what to do. Oncologists are not used to prescribing antidepressants, perhaps. Patients are worried about taking another tablet. They don't know what psychological therapy is. And even if the treatment is started, it's often inadequate. So perhaps the patient is prescribed a very low dose of an antidepressant, or they have 1 or 2 sessions of counselling. So we have this big problem. We have about 10% of cancer outpatients suffering from major depression, and very few of them are getting adequate treatment. Now, at this point, when I talk about this 15-year journey, a lot of people are frankly feeling a bit miserable, and that's absolutely fair enough. I've just given you quite a lot of rather negative information. But negative information, that problem, we can see in a different light. We can see it as a challenge, an opportunity. So what we're going to do now is see that opportunity and think about this new approach that we've developed to try and address the problem. So the first thing we need to do is improve the identification of depression. We need to address that first big problem. How are we going to do that? Well, we've designed a system to identify patients who have depression. This is a very systematic way of finding patients with depression, and it's a 2-stage screening system. So when patients come along to the cancer clinic, we ask them to complete a symptom questionnaire that has questions about common symptoms of cancer, so things like feeling tired, feeling nauseated. We ask them specific questions depending on the clinic that they come to. So for example, in a lung cancer clinic, we may ask them about whether they're coughing a lot, whether they're coughing up blood. And we also ask them some questions about depression. So that would usually be a hospital anxiety and depression scale or a patient health questionnaire. They do that while they're waiting to see their oncologist or their oncology nurse using a touch screen, like you can see in that picture at the top, or on paper. And those patients who have a high depression score then go on to have a diagnostic interview over the telephone. So we phone patients once they've gone home over the next few days to do an assessment to see whether they have major depression. And we train members of our team to do that. And we do that at home over the telephone, really because patients don't want to be hanging around in the cancer clinic waiting to be asked more questions. And this is an efficient way of doing it, and it's very acceptable to patients. So this is how we systematically identify all those patients who have major depression, those 10% of patients. Once we've identified those patients, we need to improve the treatment of depression. We need to make sure that these people actually get effective treatments. And this is how we do that. Depression care for people with cancer is a manualized treatment program. It's developed specifically by our team for patients who have cancer and depression. And it's inspired by the collaborative care approach. So many of you will be aware that our colleague and dear friend Wayne Caton from Seattle, who's a psychiatrist working there, he developed this collaborative care approach to try and improve the care of depression for people in primary care. And this is a very systematic way of working. And the idea behind collaborative care is that it's delivered by a team. So depression treatments are delivered by a team of people who are care managers supervised by psychiatrists. And the reason that we do it this way is if you think about the number of people who have depression, so in this setting, in the cancer setting, we're talking about 10% of people. We're just never going to have enough psychiatrists or psychologists, psychiatric nurses who can deliver treatment to those patients. So instead, we use a team of people to deliver treatment. And that means that the reach of the psychiatrist, of the experts, can be greater. So a psychiatrist can supervise the care and therefore treat far more patients than we could if we were seeing every patient ourselves. So how does this work in practice? Well, our care managers in DCPC are specially trained cancer nurses. So these are not mental health nurses. They're nurses who have a lot of experience of looking after patients with cancer. And we do that because we know from our interviews with patients that they want their depression to be treated by somebody who understands both their cancer and their depression. Similarly, the psychiatrists who supervise the team have expertise in looking after people who are very medically ill. So these are usually CL psychiatrists. And we see patients in the cancer centre. So this whole treatment programme is integrated into the cancer care. So not only are the patients screened for depression in the cancer clinic, but they're treated for depression there. So this is a very acceptable way of caring for these patients. It's also very practical because it means they don't need to be going to a separate mental health setting somewhere else when they're already coming along to the cancer centre regularly. So we try to integrate the mental and physical care as much as we possibly can. What does this treatment programme actually involve? Well, it involves a combination of 3 evidence-based treatments. We know that when we treat depression, there's good evidence now that if we combine pharmacological treatment with psychological treatment, we get better outcomes. So we suggest to patients that they try all 3 of these treatments. They don't have to if they're taking part in the treatment program, but that's what we recommend. And these are antidepressant medication and then 2 psychological treatments, behavioural activation and problem-solving therapy. And I'm going to tell you a little bit more about those. So our care managers, when they see patients, and they see them usually for up to 10 sessions over 2 to 3 months, they talk to them at the start of treatment about taking an antidepressant, and they address any concerns or questions the patient may have. The psychiatrist who's supervising the team would make a recommendation, usually to the primary care doctor, who would prescribe the antidepressant, and they'd recommend which antidepressant to prescribe based on the patient's history, the symptoms they have, the potential for side effects, if the patient has perhaps taken an antidepressant before and responded particularly well to it. And the medication is very actively managed in this treatment programme. So as you will know, often in standard practice, a patient may receive a prescription for an antidepressant and then nothing really happens for many weeks. In DCPC, we very actively manage the medication in terms of changes, adding antidepressants together, increasing doses, and we do that based on how the patient is doing. And that's something that I'll come back to in just a minute. So as I said, there are 2 psychological treatments that we also use. The first is behavioural activation. So this is really about being a bit more active. So if we go back to our patient, John, he's here having a short walk. And what has happened when John has had his cancer treatment is that for many, many months, he's been coming to the cancer centre and people have been doing things to him, been giving him treatments, chemotherapy, for example. So he's become really passive and not doing very much. So the idea behind being active, behind behavioural activation, is it's partly to do with exercise, but it's really also about the patient feeling that they're able to do a bit more, that they can get some sense of satisfaction and achievement. We asked them to make a realistic plan. So we would talk to John about what he's doing at the moment. If he's maybe walking to the local shop and back, he might then choose to go for a little bit of a longer walk a couple of times this week. See how that goes. And if he's achieved that, then the following week, do a little bit more again. And this is something that we can adapt depending on how the patient is. So patients, for example, with lung cancer or other very bad cancers, maybe not able to breathe very well, it doesn't have to be exercise in a big way. This could be simply walking to the front door and back again, if that's more than they're doing at the moment. And then the other of our psychological treatments is problem-solving therapy. And this is something that Raj mentioned when he very kindly introduced me. This is a therapy that I very much enjoy delivering and training other people to do. And that's because it helps the patient to cope better with their problems. It really helps them to take control and to feel confident. The way that we do this is deceptively simple. So the idea behind it is that we make a list of problems and we work on them one at a time. It's actually quite challenging to do well, which is another reason that it's enjoyable in some ways. But it's very practical, and it seems practical to patients. So again, when we go back to this idea of acceptability that I've brought up a few times already, for these patients who are coming to the cancer centre diagnosed with depression, often many of our patients have never had any kind of psychological treatment. And people, as you will know, have assumptions about what that might involve. They may expect that psychological treatment will talk about their childhood for years on end. And actually, this is something that is practical and they can get going with quite easily. And they may then decide to do more prolonged therapies later on, but this is something that really helps get the depression improving quite quickly. So this is an example of how it works. This is John's problem list. We ask the patients early on during the DCPC treatment program to write this problem list with their care manager. We don't go into the problems in detail during that session. This is just about getting a list, and the patient can add things to the list as the sessions go on. They can take things off. They can change the problems on the list. This is really something that belongs to them, and the care manager helps them or facilitates them to do. So we can see here that these problems that John has, some of them may be to do with his cancer, being worried about his oncology appointment. Some may be cancer or depression symptoms, such as sleep, but there are other things just to do with his life in general. He's not happy with his appearance since he's had his surgery. He's not able to visit his family, things to do with his relationships, such as his sexual relationship with his wife. So we ask patients to put anything on the list that is bothering them right now. It may be to do with cancer, depression, it could be anything in their life. And then, like I say, we work through these problems one by one. We don't have to get through all of the problems because the idea is to help the patient learn a technique so that they can do this themselves to be able to cope better with each problem. So in each session, we'd explore a problem, ask the patient to set a short-term goal, something that they think they can achieve realistically, that will help them feel a bit better about that problem. And this is really about coping better with the problems, not necessarily getting rid of them. List some possible ways they could achieve that goal, which we call solutions, make a plan and try it out. So if we go back to John's problem list and we take that one in the middle, the red one, John says he's feeling anxious about going out by himself. So if we see what that would look like during a problem-solving session, the first thing that we do is we talk about what that problem really means to that patient. So for John, what this means is actually that he's stopped going to his local shop. And the reason he's done that is because one of his best friends works there. And what John knows is that if he goes to the shop, Jim, his friend, is going to say, "How are you doing, John? How's the cancer treatment going?" John knows if he asks that, he won't know what to do. He'll just feel overwhelmed. He'll feel like he's going to cry. And that is the last thing that John wants to do when he's at his local shop. So we ask John to think about what would be a goal that he would like to achieve before our next session that would help a bit with that problem. That could be any goal that John chooses. This is his problem and his goal. So he could choose all sorts of ways that he'd like to address it. But he decides that what he really wants to do is have a chat with Jim. And he wants to tell him that he loves coming to the shop. He loves getting out and about, but he really doesn't want to talk about cancer there because he knows that he's going to start crying. We then ask him to think about the different ways that he could achieve that. And those are the solutions that you see there. Send him a text, give him a call, ask him to come round. And then John goes through the advantages and disadvantages of each of those potential solutions. And again, these are the solutions that John comes up with and the advantages and disadvantages for him. These could be quite different if it was a different patient. And then the really important thing at the end of the session is that John goes away with a practical plan that he's made. And for this particular problem, he decides that he'll text Jim. He'll ask him to come round for a chat on Wednesday. And he's going to do that before he makes dinner tonight. So it's important that the plan is very specific and clear, because that makes it more likely that John's going to do it. And he's made himself a note there to remember to tell Jim in the text that it's not bad news, because he realizes that Jim may be very worried if he sends him a text saying, can you come round on Wednesday? So that's an example of how we might do a problem solving session with a particular problem on the list. And as I say, we work through the list with the patient, trying to help them to learn this technique. And often as patients have done a few sessions, they say to us, I know how to do it now. And this is something that they are able to keep and take away for the rest of their life. Now, I mentioned earlier when I was talking about antidepressants that we are very active in the antidepressant management. And I said I would talk a little bit about how we do that. So one of the important things about this treatment program, and for collaborative care in general, is that we use a treat to target approach. So we monitor the patient's depression severity at each session. And we happen to do that using the PHQ-9. And we're aiming in this particular program for a 50% drop in their score and a score of less than 10. So that means when we monitor the depression score over time, we can have a graph. You can see the graph there just below John, who's filling out his PHQ-9 questionnaire. And you can see that his score is gradually going down over time, over those 10 sessions. We can look at those graphs, the care managers and the psychiatrists together. Sometimes we also look at them with our patients, and we can adjust the treatment as needed to achieve that target. Now, I talked about adjusting antidepressant medication, but it may also be about adjusting the psychological treatment. It may be that there's a difficulty with the problem solving, the patient isn't quite getting it, or they're finding the behavioural activation difficult, maybe setting unrealistic goals. And that's something that we will discuss between the care managers and the psychiatrists when we have supervision sessions. So these supervision sessions are led by a senior psychiatrist, and we review the depression scores each week. So we would discuss all our new patients and also look at the scores to see which patients needed some extra attention or their treatment to be tweaked in some way. This thing of looking at these depression scores may seem, some of you may do it normally. A lot of people find it quite unusual in psychiatric practice. And as I said, Wayne Caton was the person who developed collaborative care. And when I talked about it with him some time ago, he said, well, actually, I realized that we do this in all sorts of things in medicine. And as he was working in primary care, he saw that people were monitoring blood pressure, diabetes. Why don't we do that with things like depression? And in the oncology setting, this is just the same as my oncology colleagues measuring somebody's cancer using blood tests or scans. The other thing we do during the supervision is we watch video recorded sessions. So all of the care managers' sessions are video recorded. And this is an example here of one of our care managers with an actor. And it means that not only can the psychiatrist see how the care manager's doing with their treatment, but they can also look at specific patients. sessions. The care manager can say, I'm finding it a little bit difficult to do problem solving with this patient, or I think I'm missing something here, and the psychiatrist can help them by looking at the video with them. The other really nice thing that's a lovely side effect of these videos is that the care managers will sometimes bring a session that's been videoed and show us a before and after. So we'll see the patient at session 1 when they've come along with their depression, and later on as they are feeling so much better. So we see patients getting better, but that's just on an individual basis. What about evaluating this new approach? Does this actually work? Is it effective? Well, we've done 3 clinical trials. These are the SMaRT Oncology trials that Raj mentioned. SMaRT Oncology 1 was an efficacy trial or a proof of concept trial. SMaRT Oncology 2, which is the trial I'm going to tell you a little bit more about just now, was a much bigger multi-center RCT, so an effectiveness trial. And at the same time as we did SMaRT Oncology 2, which was for patients with quite good prognosis cancers, we also did SMaRT Oncology 3, and that was for patients with lung cancer, which at that time was a particularly poor prognosis cancer. The results for SMaRT Oncology 3 were quite similar, actually, to those for SMaRT Oncology 2. So this is the one that I'm just going to focus on right now. So this was a multi-center randomized control trial, and we asked 500 patients with cancer and major depression to take part, and they were allocated to either the new treatment program or usual care. And we measured their treatment response. So this was a 50% drop in their depression score at 6 months. And these were our results. So blue is usual care, red is the DCPC. The thing that every time I do this and make this graph come up on a slide, I'm always surprised at the size of that blue bar, because usual care in this trial was not usual care as we know it, because patients had been through that 2-stage screening system. They had a diagnosis of major depression, and so we can't just ignore that. We told their GP, the general practitioner or primary care doctor, that they had major depression. We told their oncologist, their oncology nurse. We asked them to treat that patient's depression, and we told the patients. We explained what the depression diagnosis meant and said that they should go and seek help for it from those clinicians. And as I said earlier, these cancer centres they're very good cancer centres. They have psychiatrists and psychologists, and all the patients have primary care doctors. So 17% of patients at 6 months had a treatment response. So 17% of patients had a 50% drop in their depression score with that usual care. 62% had a treatment response with the DCPC. So this is a huge difference. And when we looked at other symptoms, other outcome measures, and we did this over a year, you can see that the usual care here again is blue, DCPC is red, and on all of these measures, there is a statistically significant difference, and often a big difference, between the 2 groups. So DCPC is not only helping people in terms of their depression, but also with other symptoms, perhaps not surprisingly anxiety, but also pain and fatigue. It's helping them function better, helping them to have better overall health and quality of life. Is it cost effective? Is it expensive? It costs about $1,000 per patient, and that equates to about $17,500 per quality adjusted life year. For those of you who are interested in health economics, this is the measure that our health economists usually use. What does that mean? Well, what it means is it's actually quite a lot more cost effective, than some cancer treatments. So if you have oncology colleagues, this might be quite a good way for them to spend some of their money. So we're coming now towards the end, or where we are now, I suppose, in this 15-year journey. We've had this problem, we've got a new approach to addressing it, we've tested it in clinical trials. What about routine cancer care? Can we implement it in what some people call real life? I'm always slightly concerned about suggesting that a large amount of my life doing research is not real, but there we go. So this is the Oxford Cancer Centre. This is just across the road from where I'm sitting now. This is our main entrance. It's a big cancer centre. We have about 20,000 new referrals a year. And a few years ago, we had psychosocial support, but there was no systematic depression care. And we decided that we would try and implement this programme of identification and treatment in the cancer centre. We studied this as we did it by keeping a detailed diary. We kept data from the cancer centre. We did lots of qualitative interviews with patients who received it and staff who worked there. And this is my colleague Michael Sharp, who some of you will know, standing outside the cancer centre a few years ago as we were starting to do this work along with one of our senior cancer nurses. So what happened? What was our experience of doing this? Well, there are certainly some barriers to implementation, and these will be some that you will be well aware of if you try to implement anything in a healthcare system. There was huge organisational complexity. So our cancer centre exists as part of a hospital, which is part of a hospital system. And the number of people involved in making decisions, in saying yes to things, is just phenomenal in that kind of system. So that adds to the time it takes to implement anything. There were practical barriers like clinical space. So for many months, everything was on hold while we tried to find space for the care managers and the psychiatrists to work in within the cancer centre. And then something that might not surprise you, but did surprise me at the time, was that one of the big barriers was ownership. So the cancer centre were very welcoming. The oncologists really wanted this new system to help their patients. The psychiatrists that we work with were all very happy that we were implementing this and we were integrating mental and physical health care. But when it comes down to the practicalities of ownership, who funds this? From the oncologist's point of view, it's a psychiatric intervention. So perhaps psychiatry should be paying for it. From the psychiatry point of view, well, it's cancer patients who are going to be benefited from this. Surely oncology should pay for it. There are also some fantastic facilitators. Our oncologists were very well engaged. We had senior management engagement at the very high level, people who really wanted to improve care, but also to, as I say, integrate mental and physical health care. And I think it was really helpful that this is something that we do in the cancer centre. We're not saying that it's a separate thing that patients have to go somewhere else to get. It helped that we had such high quality research evidence, particularly in a research active cancer centre. Our oncologists all know about clinical trials. They understand what randomised trials are, and that made them feel much more comfortable about it. And I think the biggest facilitator was really just sheer persistence. We wanted to make this happen, and we carried on until it did. So where are we today? Well, this is now successfully implemented in the routine care of the Oxford Cancer Centre. It's been working for some time, and we're getting similar results to those we have in our clinical trials, which is really very unusual, but is a testament to the people who are delivering this in Oxford. So 90% of our cancer outpatients are screened for depression, and 61% of those who receive the DCPC treatment programme have a treatment response, very similar to those graphs that I showed you from SMaRT Oncology too. This is some of our team, our care managers, and Luke Solomon's our lead psychiatrist there. So this is where we are now in this 15-year journey in depression care for people with cancer. I'm going to finish this part of the journey with this quote from your wonderful Dr. Rakoff, that human suffering is a given and perennial. There ain't no escaping it, and it is the great privilege of being a physician to attempt to alleviate some of it. I hope that I've shown you that we can alleviate some of the suffering associated with depression in people with cancer, and it has certainly been my privilege to be on this 15-year journey. Just before I finish, I should just say thank you to the huge number of people who've been involved in the work that I've described today. These are just some of them. You'll perhaps recognise on the picture there Wayne Caton, who I've mentioned, and also Michael Sharp, who has been my partner in research for many years now, nearly 20 years, has put up with me very well on this journey. To also thank all of these institutions who've supported our work, but most of all to say thank you to people like John, all these patients who've taken part in our research with the aim of helping other people. And finally, just to say thank you all for being here today.
Thank you, Dr. Walker, for that wonderful, thoughtful presentation. And if it's okay with you, maybe we'll start with some questions from the audience. The first question, there was a question about brain fog. How does this differentiate from illness and treatment? How do you differentiate depression, and how is the treatment different for, quote, brain fog versus, depression, etc.?
Goodness, that's a very good question. I'm not sure that I'm very equipped to answer it, to be perfectly honest. I think it's very difficult to differentiate. And I would say really that what we would do is do a diagnostic assessment, and if the person has depression, then go ahead and treat it. And I'm quite pragmatic in my clinical practice, see how that goes. But as you know, that brain fog is a big problem for a lot of people who are undergoing cancer treatment. So sometimes the depression treatment is not going to be enough by itself.
Thank you. There's another question about, they were wondering about the role of CBT for these patients. I think from the experience, there's a lot of people with catastrophic thinking, etc. Would CBT techniques be helpful in treating this population?
Yes, absolutely. So the problem-solving therapy is in some way related to CBT, in that there's a lot of behavioural therapy and a lot of thinking about, for the patient, what that problem means for them. But it isn't cognitive behavioural therapy. We don't train the care managers to do CBT because that would take a lot longer. It's more difficult to train to do it. However, what I didn't get into here was that this treatment program isn't suitable for everybody. So we do have patients who have more complex problems who would see a psychologist or a psychiatrist in the clinic. And sometimes those patients, particularly things like body image, for example, and how people think about their body, that might be more amenable to CBT with one of our psychologists. Yeah, absolutely.
The next question is maybe, I think, two different types of questions, but the first question was about how does this intervention respond to people's sort of realistic concerns about treating patients with cancer, advanced fear of dying, etc., that existential kind of thought. I mean, what are your thoughts on that?
So how well does it work in that situation?
Yeah, how does it respond to it? How does this treatment respond to that type of situation? Yeah.
Yeah, so the SMaRT Oncology 3 trial, which I mentioned, that was for patients with lung cancer, and we had very similar findings in terms of the depression outcomes as we did for SMaRT Oncology 2. My personal experience is that I've used problem solving a lot in my work and behavioural activation for patients who are really very ill. I worked in a palliative care setting here for many years, and to be honest, once you learn the skills of how to do this, you can apply it to any problem. Now, it may be that the patient decides, or you decide with them, that you need to do some other type of therapy as well. But certainly we can. It sounds slightly strange, but I've often done problem solving with people about concerns related to dying. And I think the main thing is not to make assumptions. So what I'm worried about when I say I'm worried about dying will be quite different to what you might be worried about. But yeah, it sounds strange. We're not going to. It's probably misnamed, to be honest, because we're not solving the problems. We're helping patients to cope better with the problems.
Yeah, absolutely. I think the follow-up that they had was, how do case managers respond to talking about death and dying? Do they flag it, to you to say, like, how do we respond, or, in terms of your support?
So are we thinking about patients who are who have suicidal thoughts?
I think it's more about the case manager themselves.
Okay.
How do they feel about talking about death and dying with their clients? Are they comfortable? The managers themselves comfortable? Yeah.
Yeah, absolutely. So we decided to train people who are cancer nurses as opposed to psychiatric nurses, because they're much more comfortable dealing with people who are medically ill. And as I said, that's what patients are looking for. But we do a lot of training. So this takes usually 2 to 3 months for our care managers to train in. They do a lot of role play, they get a lot of feedback, and we do those supervision sessions where we go through the numbers and we talk about what we might need to change for each patient. But we also do what we would probably call clinical supervision as well. And if there are things that the care managers are not comfortable about, for some it might be death and dying, for some it might be sexual problems, all sorts of things, then we incorporate that into their training and supervision. Absolutely.
There's a question, I think, about some of the research things. There was a question about what percentage of the responders to DCPC were started on antidepressants. And the second one was, have you separated the medication response from the other two interventions?
So I'd have to look at the data, but a lot of patients in both arms of the trials were prescribed antidepressant medication. So it was actually quite common for patients to be prescribed an antidepressant in the usual care arm as well. What happened, though, in the DCPC arm was that there was much more tweaking and changing with the antidepressants. So because the psychiatrists were so involved and actively managing the antidepressants, there were more increases in doses, changes, those kinds of things. We can't, because of the way that our data are, we can't easily separate the psychological treatment from the antidepressant treatment in terms of what makes the difference. But when people ask me that question, my answer tends to be that as somebody who's practical and pragmatic, I think, well, we have these two types of treatment that we know are effective for depression in general. If we're seeing patients to do the psychological treatment, why would we not talk about antidepressants? If they're coming to us to manage their antidepressant, why would we not do the psychological treatment as well, given that this is something that is brief and we can teach our care managers to do in a relatively short space of time. And as I said, there is the evidence that we know now that combining, if possible, can be more effective for patients as well.
Thank you. There was a question here about, can you comment on the role of cultural factors in the response to treatment?
Certainly. So I don't have any data on cultural factors. So in terms of our subgroup analyses, they were by cancer types and sex and age, and we didn't see any differences there. I think patients, that the culture, the background that the person comes from is going to have an influence on how they might think about antidepressant medication, how they might think about psychological therapy. I would say that my own experience is that the problem-solving therapy and the behavioural activation are, because they are quite practical, most patients do find them to be very acceptable. As I say, sometimes we move on to other therapies as well, but they do tend to be pretty acceptable to most patients.
Thank you. The next two questions, I think, around the same point. What happens to the 40% of the patients who don't respond to the treatment, or the other one was about 39% who don't achieve the treatment target? What were your thoughts on that, on the ones that don't respond?
Mm-hmm. So what we would normally do in the treatment program is, if the patient is not responding to treatment, So essentially the DCPC has not been the right treatment for them, then we would either the psychiatrist would see them, or they may require referral on to somebody else. So sometimes these patients are referred from the treatment program into our community mental health services. It may be that actually they need a different type of treatment. It may be just that there's some other difficulty as well as the depression. So yes, so what I should have said really is that DCPC is not a replacement. We're not trying to replace psychiatry, psychology, community mental health services. This is in addition.
Yeah, thanks. The next question was, in your routine implementation, does your collaborative care model include an oncologist in the team review?
Good question. No, they're not in the team review. And that is, it's an interesting thought actually, how we could potentially do that. We had oncologists involved very much in the development of the treatment program and in the clinical trials that we did, and our oncologists here in Oxford are very bought into the treatment program, but there are a lot of them, to be honest, and so I'm not quite sure how we would have them involved in the team. We certainly communicate with them an awful lot, and I think because the care managers and the psychiatrists are based in the cancer centre, they see them a lot. So there is a lot of communication in a very informal sense as well. But no, it's an interesting question. We don't actually have one in the team.
Thank you, Dr. Walker, for this wonderful presentation. It's very engaging, and I know we had lots of questions, and there's so many people saying it's an excellent presentation, and they obviously, we really appreciate you presenting all the way from Oxford on the special lecture, Vivian Rakoff's memorial lecture. I love the fact that you integrated some pictures and some quotes from Dr. Rakoff as well, so that was very, very thoughtful. So thank you again. I just wanted to tell the audience we do have a major conference coming up, the Future of Psychotherapy, April 26th. And on that day, we'll have our next special grand rounds as well. So please consider coming. We've got Dr. Holly Schwartz, who's a prominent researcher from University of Pittsburgh, who is speaking. We've got really good presenters from University of Washington and Addis Ababa from Ethiopia, and Dr. Paula Ravitz is doing a wonderful presentation workshop as well with Dr. John Hunter. We also have another workshop on social rhythm therapy from Dr. Holly Hunter. So hopefully we'll see you there. And we do have feedback survey, and if you wouldn't mind completing that, that'll be really helpful for us as well, and we will share that with Dr. Walker at some point as well. So thank you, everyone. We'll see you next time. Take care. Bye.